Auzu billahi minash shaitanir rajim. Bismillahir Rahmanir Rahim. I'm Professor Dr. Sarfraz Hussain Sayyed, Professor of Ophthalmology, Head of Eye Unit 2, Punjab Medical College, Faisalabad Medical University, Faisalabad. Today we are going to discuss about the examination of the cornea. Essentially, the examination of cornea is performed by the microscope and illumination system, which in its modern form is slit lamp. There are different ways we can examine the cornea with slit lamp. Diffuse illumination is when we open the full beam of illumination and we look at the cornea as a whole and see whether there is any abnormality in the cornea or not. Focal illumination is when we see a lesion in the cornea and we want to see the and assess its details. We need a focal illumination, that is with a we make a slit and at one angle we have the illumination and the other we have the observation system, and we look at that lesion and we can diagnose with this the subtle lesion in the cornea. The scleral scatter is when we have illumination at a certain angle to the observation system, and with this we can see even a very subtle opacity in the cornea. Retroillumination is when we illuminate part of the surface behind the structure behind the cornea, and we look at the reflex through the cornea and the lens. With this we can see the abnormalities of the iris as well as we can see the abnormalities in the media. The specular reflection is when we see the endothelium with the system. We focus our illumination system at the endothelium and we perform the retroillumination, by which the illumination system is focused behind at the iris, and we can see the details or abnormalities of the endothelium. Other systems and equipments we can use for corneal examination is keratometry, which is a assessment of the power of the cornea at different angles of the cornea. This is normally used for calculation of the intraocular lens implants. Corneal topography is to assess the irregularities of the corneal surface. There are special equipments which can be used called corneal topographers, and they give even a very minute abnormal, they can assess the very minute details of the corneal surface, both the anterior and the posterior. The central corneal thickness is very important to know, especially when we are checking the intraocular pressure and we relate it to diagnosis of glaucoma. The specular microscope is used to count the endothelium of the cornea. There are other new equipments coming on the way, but we are going to discuss it in a later corneal examination lecture. Now, how to document the clinical signs? We should take either a photograph or make a diagram when we are looking at the cornea and the anterior chamber, and the diagram is useful to document the corneal lesions initially and later on for the follow-up and the effectiveness of our treatment of the disease. The opacities, the scars, and the degenerations are colored as black. The epithelial edema, they can be mentioned by black circles here. And you can see the black circles here, and also the anterior surface becomes irregular in epithelial edema. And the stromal edema, we should use the blue shading with the blue color, like you can see here. The hypopyon, we use a blue color. We use yellow color here and yellow color here. The blood vessels are mentioned with a red color, and the pigment over the cornea, usually at the posterior surface, we color it with a brown shade. There are special signs of the corneal inflammation and other signs in the cornea which lead us to the differential diagnosis of the disease of the cornea and also the provisional diagnosis, which can be further assessed by the other investigations. These either should be taken a photograph of these corneal lesions, or they should be drawn in a diagram. The superficial lesions can be punctate epithelial erosions. These are small defects in the epithelium which appear as small whitish areas. It can be caused by some diseases which can be provisionally diagnosed from the location of these punctate epithelial erosions. The superior location is in vernal keratoconjunctivitis, superior limbic keratoconjunctivitis, floppy eyelid syndrome, poorly fitting contact lenses. In the interpalpebral area, the dry eyes, reduced corneal sensation, and exposure to the UV light can cause a punctate epithelial erosions. Inferior location occurs in blepharitis, lag of ophthalmos, toxicity from the eye drops, and habitual self-induced or mucus fishing syndrome. Punctate epithelial keratitis appears as granular opalescent swollen epithelial cells which stain well with the rose bengal. You can see these opalescent areas here. These are caused mainly by the adenoviral infections, chlamydial infection, Thygesson's superficial punctate keratitis, and staphylococcal hypersensitivity. The mucous filaments, these are walls of mucus lined with epithelium attached at one end to the corneal surface, hanging over it. It moves with the blink, and these are caused by dry eyes, superior limbic keratoconjunctivitis, corneal epithelial instability, neurotrophic keratitis, eye patching, essential blepharospasm. Corneal epithelial edema, it appears as loss of the corneal luster, and in severe cases there could be vesicles and bullae over the corneal surface. It is caused by the endothelial decompensation or severe acute rise of intraocular pressure. Superficial vascularization is caused by chronic ocular irritation or hypoxia, as in contact lens wearer. The pannus is a non-specific and occurs in chronic surface inflammation of cornea. It is a fibrovascular tissue extending into the subepithelial tissue centrally from the limbus. These are the fibrovascular tissue extending into the cornea. The deeper lesions could be infiltrates. These are focal areas of active inflammation composed of accumulation of leukocytes and cellular debris. It appears as focal granular gray-white opacities, usually within the anterior stroma. A surrounding halo of less dense infiltration such that individual inflammatory cells are discernible. It could be caused by the non-infectious inflammations or infections. PADL is a mnemonic to distinguish infectious from non-infectious infiltrates. The P is for pain. Pain is more in infectious than non-infectious inflammations. Epithelial defects, these are more in the infectious than non-infectious and usually are present in the center than at the periphery. Discharge, the purulent discharge is typically associated with the infections, and usually the watery discharge is associated with non-infectious infiltrates, but there could be mucopurulent discharge in non-infectious infiltrates as well. The anterior chamber reaction can occur both in the infectious and non-infectious, but it is more in the infectious keratitis than the non-infectious keratitis. The central location is associated with the infectious, and the peripheral location of the ulcer or keratitis is associated with the non-infectious, because that is an autoimmune condition, and where there are more vessels there is more autoimmune reaction. Ulceration is loss of the epithelium and melting of connective tissue by enzymatic breakdown from infiltrating white cells or bacteria, fungi, and amoebae. Central is usually because of infections, and peripheral is immune modulated. Here you can see a central ulcer here. Vascularization of deep stroma occurs in chronic inflammation and stromal edema. Lipid deposition is a result of leakage from the corneal new vessels in chronic inflammation. Folds in Decime's membrane called striate keratopathy, where these are irregular folds in a crisscross appearance caused by the surgical trauma, ocular hypotony, or stromal inflammation. The breaks in Decime's membrane, these are due to the corneal enlargement, birth trauma, and keratoconus. You can see there are breaks in Decime's membrane horizontally orientated. This is the break, and these are the two edges of the break, which contains the rolled edges of the Decime's membrane. This is called Harb striae, occurring in the corneal enlargement in congenital glaucoma. Now we are discussing the principles of treatment. With each section of the disease, we will be discussing about the specific treatment related to that disease. But as a general, what principles are laid down to treat a corneal disease are like control of infections and inflammation. For infections, we need antimicrobial agents, and for inflammation, we need topical steroids and systemic immunosuppressive agents. The second principle is promotion of healing by promoting the re-epithelialization. This can be performed by reduction of exposure to toxic medication and preservative where possible. The lubrication with unpreserved artificial tears and ointments. The eyelid closure may be sometimes required if the healing is not progressing properly, and this can be performed either by simple taping with a tape, closing the lids together, or by giving an injection of botulinum toxin A into the levator palpebris superioris, leading to the ptosis by lateral tarsorrhaphy and medial conjunctivoplasty. We can also perform a conjunctival. A bandaged soft contact lens may also be applied to improve the healing and to decrease the pain due to the irritation and photophobia. We can also perform the amniotic graft to improve the healing and also give it a support. The tissue adhesives sometimes can also be used, and limbal stem cell transplantation can also be performed in case of resistant cases. Now here you can see this one. The tape has been applied to close the lids here, and this is the lateral tarsorrhaphy performed here. This is a conjunctival flap, also called bucket handle conjunctival flap, which has been applied over the corneal ulcer here. This is a bandage contact lens for there. This is a graft applied over there. And this is a graft of the limbal cell applied over there.